Thank you for listening. I've been asked to do this second talk on functional, or also called non-organic visual loss, but that's already arriving at the diagnosis. So where I'd like to start is a little further back, where we don't know the diagnosis yet, and so we're going to start with just unexplained visual loss, okay? And so when we have the patient who's complaining of visual loss, and you look at the eye and you look at all the tests and there's nothing that you can find, then we say this is unexplained visual loss. And for many, the next step is neurology or neuro-ophthalmology. Maybe this is optic nerve disease, maybe this is cortical visual loss. And if it's not neurologic visual loss, then again, for many of us, the next step is to jump to thinking it's non-organic. But I would pose that there's another in-between step. It's not ophthalmologic, it's not neurologic, and I would just remind you that sometimes unexplained visual loss is simply because we missed something, what I call a clinical pitfall, okay? And these are three fairly common pitfalls. I'm certainly as guilty as anyone else of making these pitfalls. So I just want to share with you two cases regarding these. So one is just not specifying the chief complaint, accepting what's written maybe on the form by the technician and not getting a better history. Another pitfall is simply overlooking some critical clinical finding, and the third is not ordering the right test for the pathology. So it's fine to order MRI head and orbit, but in certain pathologies, if you forget to mention that you should fat saturate the orbit scan or do it with contrast, you will miss the pathology that is truly there. So let me just share with you again two short cases of pitfalls that were initially thought maybe it's functional. Okay, so this is a 25-year-old university student. He's in the master program doing finance or accounting, something with numbers. And he has a new blur in his left eye. And it's causing difficulty reading. He's getting headaches. Work is getting harder. But on exam, he's 20/20. Okay, sometimes he's 20/30, but you can push him to 20/20. And the pupils are normal, and the fundus here, to me, it looked normal, unless you see something. And we did the visual fields. They look normal. We even went as far as multifocal ERG normal, macular OCT normal, and ready just to say, maybe he's just a little anxious or has dry eyes, maybe a functional component, hard to know. But what did we miss here? And so I would counter that we just missed the history. Okay, we accepted the writing visual blur by our nurse, but when we said, wait, so back up, what do you mean by blur? Okay, he said, oh, well, that's easy. There's a spot right here, and it blocks half the word or half a large number. Remember, he's working with very large rows of numbers. So for example, 13326, sometimes he thinks it's 18326, 10026. What's only clear is 26. So now we have a better feeling that this is a paracentral defect. So what we missed was not doing the right test. And so we should have done some better central testing. That could have been a tangent screen or an Amsler. Or in this case, we sent him back for the macular 10, and there it is. Okay, he really does have a paracentral scotoma. Okay? So now we have something, and we do further workup, autofluorescence, fluorescein angio. As we're doing these tests, orbit MRI, inflammatory workup, his scotoma is getting worse. Okay? And about a month later, you can see that he has now an easy scotoma on the 30-2, and 3 months later, finally we figured it out, he has labor hereditary optic neuropathy, 1170-78 mutation. Again, I was thrown by the fact that one, his complaint was very vague, and secondly, the initial visual field defect was so darn small for a Leber's that it finally announced itself. So not functional. Another case, a 61-year-old woman, same thing. I have a blur in my left eye. Now this time we're really trying to push the history and get, is it a scotoma? Is it a metamorphopsia? What is it? She can't be more specific. And same thing, we can get her to 20/20. Her Amsler grid is normal, her fundus is normal. Can you play the video again? The pupils look normal. Video, please. Okay, and she has a lot of stress in her life. Her husband recently had a stroke. So now she has to do the lawn care, she does all the driving, she does the bills, everything. Yeah, so this was called the normal pupillary exam. So if you call that normal, of course, this case is difficult because she has a blur. We don't find anything. The OCT looks good. She's got some nuclear sclerosis, so she was told, well, probably your cataracts are starting to bother you, come back in a year. But she was very, very unhappy with that, continued to be very anxious, and finally convinced her family doctor to order an MRI. This is not even an orbit MRI, this is just a plain head MRI, and I think we can all see the big meningioma compressing the left optic nerve. So again, this is not functional disease. It might kind of sounded a little crazy at first, but in fact, she has real optic neuropathy, and what was the pitfall? Right, is just kind of missing the RAPD on the test. Now, why would we miss an RAPD? And in this case, I would pose that it was missed because the testing was done in room light. And I think somebody mentioned this earlier, is always check the pupils in dark. So now we're going to turn the lights off, and we'll do the RAPD testing again. And if there's the reaction in the right eye, okay. And now we're going to swing to the left eye and back and forth. You can see already it's less reactive, but when you swing, right, this is kind of a medical student RAPD, the kind that you would like to show medical students because it's so obvious. So had we known that, had that had been picked up by the assistant, then we would not have at all called her a cataract. This would have been easily a left optic neuropathy. So the message again being, in this case, the pupils remain a wonderfully objective marker of neuroretinal integrity. RAPD testing is very sensitive and sometimes the only sign of an optic neuropathy. But you can count on the RAPD testing only if you perform it correctly. Okay, so just two examples of pitfalls that were initially kind of moving in the direction of maybe if it's functional disease. It was not at all functional disease. Okay, so now we will talk about non-organic visual loss, okay, or functional visual loss. And the big difference between just simply unexplained visual loss and non-organic visual loss is that there's something mismatched, something not quite right about what the patient is saying and how the patient is behaving, or by what you're finding on your exam. It's mismatched, okay? And that makes us suspect that there's a functional component. So our objective as physicians is we really need to demonstrate that mismatch. For us to say it's functional, you have to have some objective evidence that the visual function is better than what the patient is claiming. It can't be your suspicion. You have to show it's better than what the patient says, okay? So let's start with the patient who is claiming monocular visual loss. Count fingers or claiming they can only see the moving hand, okay? Our job is to establish some level of visual acuity or visual function that's better than that. And there are many strategies that you can use, but I want to talk about three, and the three basically that I use, okay? So for monocular visual loss, I will start with a Mojon optotype chart. This is commercially available. You can buy this. It's a little card about like this, front and back. This is a monocular test. Okay, so you must cover the good eye. This is not a test of acuity. This is a test of basically the patient's honesty. How honest is the patient being in his or her responses? So it just gives me a feeling right away, are we being frank with each other? Okay? And the reason this is an honesty test is because if you can see the first big arrow, okay, on the card, you can see all the arrows, no matter how small, because this is based on the frequency of the black and white lines. And the line comes because they've just shifted the black and white lines. So you get an illusory contour. Okay, so as long as we don't change the frequency of the black and white lines, you should always see a line when there's a shift. Has nothing to do with acuity. But the patient thinks it's an acuity test. The patient thinks if they can see the big arrow, then they better not see the smaller ones, and that's false. Okay? So the way you do this is you start by showing only the big arrow. Can you all see this? Or should we turn down the lights a little bit? So again, there are no lines here. It's a shift of the black and white parallel lines that creates this contour that makes an arrow pointing up. So your first question is, can you see the big arrow? Which way is it going? And if the patient says going up, now the patient should see all the arrows. Okay, we've not changed any of the parallel lines. So you can see this one going left, down, right, and again, the patient that can see this arrow should see these small arrows. It is not an acuity test. If the patient stops here or stops here, that's not physiologic. So now we're a little suspicious that the patient is not being quite honest about his or her level of vision. Okay, so that's my first test, is just how honest are we? Now I'm going to try to get the level of visual acuity. So now I'm going to do binocular testing. So then I take the patch off, okay, because now I'm going to tell the patient, well, let's give your bad eye a rest. Let's test your good eye. But we'll leave the bad eye open. So now we're going to do everything binocularly, and the easiest one is the Titmus stereopsis test. It's stereoacuity with a polarized vectogram. I think you all know this. And what I was taught many, many years ago when I was a fellow is if with the glasses and 2 eyes, if you can read all 9 circles, this is 20/20 in each eye. A more recent study would suggest, no, it just means that the bad eye is somewhere around 20/40, 20/60. But it's certainly not count fingers. Okay, so this is such an easy test, and you tell them to read the dots with their good eye, but of course you know they have to use both eyes. And if they can read 6, 7, 8, 9 dots, they have some level of acuity. Okay? Now you can get even more precise by doing the prism test. Do any of you do this prism test? Hands? A few. Okay, so this is so darn easy, and so I would like to explain this to you. Again, the patient has to keep both eyes open, okay, and you have to tell the patient, we're going to test your good eye, okay? And you take the acuity all the way down to the level of acuity of the good eye, which is usually 20/20, 20/25. And you pick one letter, and you say, okay, you see that with your good eye? Yes, 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 I see that. Okay. Now, you're going to tell the patient that, let's see if we can make your good eye better. I'm going to give you a lens, but it's not a lens, it's a prism. So for just 2 seconds, maybe 3, not more, you throw a prism in front of the eye, and what's going to happen to the image? It's going to jump up, right? So in the good eye, it jumps up, but in the bad eye, it stays here. So for 2-3 seconds, the patient has diplopia. But you say, so did you see better with the lens? What happened to the letter? And if the patient says, it was weird, I saw 2. Gotcha, that means you have 2 good eyes who can see 20/20. Okay? Now, if the patient really has poor vision, then the letter will jump up, but there will be nothing on the bottom because the bad eye sees nothing. Okay, so when the acuity is fairly symmetric between the two eyes, the patient has a few seconds of double vision, and if the vision is truly poor and the patient can't read that K, they'll just mention that the letter jumped up, but it's still clear. How good is this test? Well, one of our colleagues, Carl Golnick, used this test in 35 patients with unexplained visual loss. And in the 4 patients who had true organic disease, this test identified them. And in the 31 patients with non-organic functional disease, this test identified them. Okay, so there's a certain fluidity to your movements. You can't hold the prism too long there because then the patient starts checking, right? What are you doing? So it's just a few seconds. There, was that better? What happened? Okay, so those are the 3 tests that I use for monocular functional visual loss. Now, what about bilateral functional visual loss or just bilateral visual loss? Let's start generally. This is a 58-year-old woman. She went to emergency orthopedic surgery for a broken hip and broken leg after a car accident. And now she's coming out of surgery, and as she's waking up from her anesthesia, she says, "Oh my God, I'm blind." Okay, so you're called immediately to see her, and what she claims is hand motion just right here. Okay, nothing here in the periphery, so it looks like tunnel fields. Fundoscopy is normal. And she goes for an emergent CAT scan just to make sure no hemorrhage. So no hemorrhage. My question is just what bedside test would be immediately helpful right now to know grossly where is the lesion? Like what test would you want to do? I think I heard it over here. Right. The pupils, right? So look at the pupils, because in this scenario, right, bilateral visual loss, severe visual loss, if it's due to bilateral optic nerve disease, like perioperative ischemic optic neuropathy, certainly happens, then those pupil responses should be very, very weak or just absent. And if it's bilateral central retinal artery occlusions from fat emboli or something, same thing, no pupil responses. But in this very same scenario, if the pupil responses are brisk and fast and robust, could be cortical visual loss, but now you start thinking functional or non-organic, okay? So in this patient, the pupils were normal with bilateral hand motion vision, okay? So again, my job is to try to determine, is it really hand motion vision or is it better? And the 2 reflexes that I like to use are the optokinetic drum and what I call a rocking mirror test. If the patient moves the eyes to either of these reflex tests, the vision is certainly better than hand motion, better than count fingers. It's usually even better than 2400. So here's the optokinetic drum test. It's a big drum. You rotate it slowly, and you have to put it right in front of their face. If you hold it here, then the patient will look at something else and the eyes will never move. You have to put it right in front of their central visual field. And just rotate the drum and ask the patient, "Do you see anything?" And the patient says, "No, I see nothing at all." But if you're watching the eyes, the patient is seeing something. Okay, so now again, I'm still suspicious that vision is better than claimed. Another one that is very easy and fun to do is the rocking mirror test. And for this, you need a big mirror like you can see here, okay? You have to go right in front of the patient again. So a little compact mirror, ladies, that's not gonna do it. You need a big, bathroom-sized mirror. So you put it in front of the patient. The patient can't fix on anything except what's in front of him. "Do you see anything?" And he's saying, "No, I see nothing at all." Can you run the video, please? Video, please. So this is how you are holding the video, mirror very closely. This is what the patient sees because he sees only what's in the mirror. It's not really moving for him. And here's what you see for the patient who claims to see nothing at all. Okay, so again, a discrepancy in the behavior and the claimed vision that makes the suspect functional. Now, our patients seem to have tunnel visual fields by confrontation, and we did automated perimetry, and it certainly looks like tunnel fields, right? The fundus is normal. Could this be cortical? Where could we have a lesion that causes this kind of visual field? Well, there are many places. This could be cortical visual loss. If the pupils were poor, you could think bilateral artery occlusions with cilioretinal artery sparing. End-stage glaucoma looks like this. So just the fact that it's tunnel doesn't immediately make it non-organic. There are organic causes of tunnel vision. But what makes it organic tunnel vision is the fact that it will expand, okay? So let me just, back up and talk about the occipital lobe and the primary visual cortex. So as you remember, the occipital lobe is exquisitely congruous, right? The fibers are one-to-one exactly placed. And the macular field is a big part of that occipital pole. And in fact, it's so important that occipital pole, the macular field, has a dual blood supply. Now, what does that mean? That means if one blood supply is embolized or ischemic or thrombotic and you get a homonymous hemianopsia, the other blood supply will spare the macula. So you can see this little sparing here, but it's otherwise a complete homonymous hemianopsia. And if you have bilateral occipital lobe lesions, you get one homonymous hemianopsia with macular sparing, and you get another homonymous hemianopsia with some macular sparing, and so you get tunnel fields from bilateral occipital lobe strokes. Okay, so it's certainly possible, and for our patient, this is possible. So my job is, again, is this real or is this functional? So now I'm going to do some testing to see if there's a real or functional component. As we mentioned, real tunnel vision, if tested here, is about this big. If tested here, it's going to expand. And the further I get away, the even tunnel vision has to expand, okay? But non-organic functional tunnel vision always stays this small, okay, for however long the distance you're going to test. So I'm going to show you how I test for tunnel vision. So in this patient, she's claiming tunnel vision in both eyes, and we're going to look at this. Okay, do you have the audio? Can you play the audio? No, the other video, please go back. Back up one video. And then could you add an audio to that? Just turn on the... And keep looking here. Mm-hmm. Tell me, do you see anything coming to your view? Okay, so about here. Okay, stay looking at me. And let's go. Okay, so about here. Keep looking here at me. Do you see my hand? Not yet?
Here.
Here. Okay, so this is where you see. Now I want you to keep looking at me, but I'm going to back up. Do you still see me?
Yeah.
Okay, here we are.
Further back.
Now,
It's quite difficult.
Oh, it's blurry? Okay, but stay here. Do you see my hand? Not yet?
Yeah, here.
Here. Okay. And keep looking at me. Do you see my hand? And tell me when.
Here.
Good. And keep looking at me. Tell me when you see my hand.
Here.
Here. Okay.
So she has
One more
these
time,
teeny
look
tiny
here at me.
fields.
Tell me when
No
you see
matter
my
how
hand.
far I go away.
Here.
It's going to be like a telescope.
Now, wait, please don't play the video. So now, Okay, I really suspect she has functional disease, so I'm going to change her attention. I'm going to tell her, okay, I understand your vision is bad, but sometimes bad vision comes with bad coordination. So let's forget the vision. Let's just test your motor skills and your coordination. So I'm trying to distract the patient, okay? So watch what she'll do when she's not thinking about her tunnel vision anymore. She's thinking about doing the motor test. You can play the video, please, with the audio. Motor functions here. So do you see my finger?
Yeah.
Okay, go ahead and do like I do. Good. A little faster. Good. And do you see my hand?
Yeah.
Okay, just a little faster. Good, good. Okay, and do you see my finger?
Yeah.
As quickly as you can, touch my finger. Good. Stay here, touch my finger. Good. And up here, touch my finger. Look at me. Touch
That's
my
a pretty
finger.
good visual
Here we go.
field
Faster,
now.
faster, faster. Good. All right. So at this point, I have thank you. I have ashamedly tricked the patient into demonstrating what is her real level of visual field. And I will now say fairly confidently that there's a functional component to her visual loss. Now, patients who have functional visual loss comprise a few percentage of our consultations, but they take up so much time. But I would wager that it is worth your time to do this, to understand if there's a functional component, because 15, maybe 20% of them actually have something, but it's so small that they're just trying to exaggerate what they have because they're trying to convince you that they're ill. So do remember that underneath it all, they may still have a subtle underlying organic disease. The other reason that it's so important that we, if I can tease out the functional component, is because once you're fairly sure that most of it's functional, it's so easy then to be confident when you reassure the patient. It's so easy to tell them with your own heart that, you know, I think the capacity to see is there. I'm sure your vision is right now just blocked, but it will be better. And the reason you can say that is because you've already demonstrated to yourself it's better. So the good news is that many patients do then get better as suggested by you. So I think I'll stop there on functional. And if there are any questions.